A variety of drugs are available for the treatment of obesity, but they are not adequate. So these are some of the limitations. So the weight loss is only the modest. So only we can achieve modest weight loss, and often it is not durable. Whenever the patient stops the medications, there will be rebound increase in the weight. So the drug intolerance adverse effects also one of the reason for the non-compliance from the patient side, because we have many drugs starting from orlistat and this phentermine, and recently GLP-1 receptor agonist also they are using for weight loss. But the drug intolerance is a major issue, like GI disturbances can occur, patient can have diarrhea and bloating abdomen. All these things, that the complaints be decreased from the patient side. So they have got different efficacy and safety profiles. No general treatment algorithm is available, because the treatment should be individualized. For each patient will require different treatment approach. These are some of the limitations of medical management. And what are the benefits of metabolic surgery? So it provides significant and greater weight loss. So up to even 50 to we can achieve 50 to 60 kg weight loss also maximum, and it improves diabetes control, and it can achieve remission in majority of the diabetic patients after metabolic surgery. So many patients, so they remain free from diabetes. So remission can be achieved, and there will be improvements in other obesity and related conditions such as hypertension, and even the cancer incidence also will come down significantly. So the patient will have better quality of life, and the sense of well-being, physical well-being will be there after metabolic surgery. And what's the rationale for metabolic surgery? So due to the tendency for basal metabolic rate to decrease with the dieting, most people will regain all their weight returning to the previous homeostatic set point. This is the problem with medical management. Whenever we perform metabolic surgery, it appears to alter this mechanism and reset this point. So the points will be reset with a 15 to 20% of weight loss and maintenance up to 20 years. So the weight loss is durable over the period of 20 years. This leads to long-term survival benefit and improves obesity-related diseases and quality in life. And there are various mechanisms. So for this metabolic surgery, so it extends beyond weight loss. It's not only weight loss. So it is, the benefits are beyond weight loss. It causes depletion of liver fat and subsequent improvements in the hepatic insulin sensitivity and clearance. There will be very good improvement in the insulin sensitivity. So the improved incretin levels is another factor responsible for the better outcome, and the changes in the inflammatory and adipokine profiles also noted. This is the flow chart. So after performing metabolic surgery, it causes, so the patient will decrease the calories and increase ileal nutrient delivery instead of duodenum. So there will be malabsorption, and there will be increase in bile acids, and gut microbiota also improved. So the ultimate results are decrease in weight, increase in incretins, and decrease in insulin resistance, and increase in insulin secretion. Ultimately, it causes diabetes remission or improvement, and so the final result is decreased cardiovascular events and decreased mortality. So this is what are the inclusion criteria. So the patients, you have to select the patients correctly for better outcome. The age should be between 18 and 60 years, and body mass index should be more than 40. That means morbid obesity, and the patients BMI of more than 35 with the significant comorbidities such as heart disease, diabetes, hypertension, sleep apnea, and so on. And there's we can consider metabolic surgery if the patients with the BMI of between 30 and 35, if their diabetes is poorly controlled with the available means. The history of prior weight management attempts and motivation and engagement in lifestyle modification. So we can select these patients from this category. And what are the exclusion criteria? So patients already having cardiopulmonary disease and current usage of illicit drugs, tobacco use, and alcohol use patients should be excluded from this treatment. And lack of comprehension, reversible endocrine disorders with obesity, because it's a reversible cause, we need not do complex metabolic surgery in this group. So uncontrolled severe psychiatric illness is also a contraindication. And this is algorithm how to select the treatment option for patients with obesity. So we have to divide based on the BMI. If the patient's BMI is less than 30, so we can go for non-surgical management. If it is more than 30, so we have to divide whether it is class 1, class 2, and class 3. So class 3 patients, straight away we can recommend metabolic surgery. And class 2 patients, if the lifestyle management and medical management is not sufficient, so we can recommend metabolic surgery. And in patients with class 2 and class 1 obesity with the poor glycemic control, we can consider doing metabolic surgery. This is algorithmic approach. And what are the surgical options available? So we have three mechanisms by which the surgical procedures work. One is restrictive procedures. That means we are restricting the intake of the intake. So by restricting the capacity of the stomach, by performing sleeve gastrectomy and gastric band surgery and vertical band gastroplasty. And malabsorptive procedures, the bypass, jejunal-ileal bypass will be done to bypass the duodenum. It prevents the absorption and causes malnutrition. That way it improves the weight loss. So some of the procedures, so they provide both restrictive and malabsorptive. The examples are Roux-en-Y gastric bypass surgery, duodenal switch surgery, and sleeve bipartition. We'll discuss one by one. So this is a Roux-en-Y gastric bypass surgery. It is started way back in the year 1960s. So here they will construct a small pouch in the proximal stomach, and they will connect it to the distal jejunum by bypassing duodenum and proximal jejunum. So thereby it causes both restriction of intake as well as the absorption defect. Thereby it works very well. So it provides a greater weight loss up to 60 to 80%, and changes in the gut hormones that reduce appetite and enhance satiety, and typical maintenance of more than 50% excess weight loss. The disadvantages are the procedure is very complex, and it can produce vitamin and mineral deficiencies. It requires longer hospital stay, and some of the patients they can develop internal hernias also. The next one is sleeve gastrectomy. Here along the lesser curvature, so they will resect the greater curvature. 70 to 80% of the stomach is resected. The remaining part of the stomach will form as a sleeve. So it's a very small portion. So there will be restricted intake, and there won't be any malabsorption here. Only the intake will be restricted. This procedure also started in 1960. Here also the significant weight loss can be achieved. So the hospital stay is shorter, and it changes the gut hormones to improve the satiety. So it will reset this neurohormonal mechanism, thereby it improves the satiety and causes weight loss. So disadvantage is a non-reversible procedure because the greater curvature of the stomach is resected, so it cannot be reversed. And again it can produce vitamin deficiency, there will be leak, and potential weight regain also is there. It's the disadvantage. And the third one is the duodenal switch. Here also they will perform the jejunal-ileal bypass to bypass the nutrition absorption from the duodenum. And again it provides greater weight loss, and this allows patient to eat near normal meal because the stomach capacity is not restricted. Disadvantages are higher complication rates and the risk of mortality. It requires longer hospital stay. It's a complex surgery. And this one, next one is vertical band gastroplasty. Again, so they form as a pouch, small pouch, by stapling the stomach in the proximal portion. Thereby their intake will be restricted, and so there will be restricted caloric intake, and it provides weight loss by this mechanism. So the last one is adjustable celastic gastric band. It's a very simple procedure. So they will fix a band in the proximal stomach to restrict the stomach quantity, and the port placed under the skin. So we can adjust, we can inflate the pump. So by injecting saline, so it can be inflated or deflated. So by this mechanism, the stomach capacity is restricted. So there will be decreased intake and ultimate weight loss. So what are the clinical trials data to support? So this is a 5-year, they have studied, in this trial they have studied 5-year changes in body weight and the rates of diabetic remission and changes in glycated hemoglobin. The first one is changes in body weight. So it's a greater weight loss achieved.
Joseph sir, yes. Kindly finish it in another 1 more minute.
Okay. So the next one is the diabetic remission. Remission at the end of 5 years is very much greater in patients, those who are undergoing this procedure. And the changes in glycated hemoglobin also is significant by this procedures compared to the medical management. And what are the complications? So there can be general complications like sepsis, bleeding, cardiopulmonary, and death also, the rate of death should be very, very low in the appropriate setup.